Hi, this is Dr. Bhargava, and I have a few interesting cases to share with you in this short video. Our first patient has history of lung cancer and presented for a FDG PET-CT study. And here's the rotating image showing a large irregular focus of intense uptake in the anterior aspect of the abdomen. Now, this focus, seen right here on the fused axial image, corresponds to abnormal soft tissue seen just below or posterior to the abdominal wall musculature in the omentum. So the CT imaging shows omental caking and the PET image shows hypermetabolism. So this patient has peritoneal carcinomatosis. The other images show that there is non-FDG avid ascites seen here as free fluid around the liver and also around the spleen. So what kind of lung cancer does this patient have? This is a review article on peritoneal carcinomatosis in lung cancer patients, and these authors say that it is the large cell carcinoma and adenocarcinoma patients that are predisposed to or develop peritoneal carcinomatosis. Our next patient has history of a salivary gland tumor. This is their rotating image, and we can see focal hypermetabolism in their left parotid. That's the site of their primary tumor. And just inferior to that, we see some additional foci of increased uptake suggesting metastatic disease. So here are the fused images showing the parotid tumor. This turned out to be a myoepithelial carcinoma, and this is level 2 hypermetabolic lymphadenopathy. And the interesting finding here is that more inferiorly there are these cystic or centrally necrotic lymph nodes that do not show hypermetabolism, as we see here on this fused PET-CT image. So remember, there are certain malignancies that lead to cystic or necrotic mets, and we may not find focal hypermetabolism just like we see in the solid organs with cystic or necrotic mets. There may be some mild peripheral FDG uptake, but centrally there is usually no FDG uptake. So remember to look at anatomic findings on the CT on such patients. This is a good article on the role of FDG PET-CT in head and neck and salivary gland tumors. Our next patient presented for a DXA scan, and here the interesting finding is that on their prior study, which is on the right, we find that in the region of their left femur, their bone mineral density is low, and since the T-score is less than -2.5, osteoporosis was called. They underwent treatment, and post-treatment, 2 years later, we find that they have responded to treatment, and now their bone mineral density has improved, and their WHO classification has moved from osteoporosis to osteopenia. So a good example of seeing response to treatment in patients whom we diagnose with osteoporosis on a DXA scan. This is a good article on assessment of body composition. I personally feel that this is the next step of utilization of a DXA scanner, where we have moved from scanning the patients to diagnose osteopenia, osteoporosis, assessing response to treatment, doing vertebral fracture analysis, and now to body composition imaging. I think in future this will be more common use of a DXA scanner. Here's our next patient diagnosed with prostate cancer. At the time of staging, I'm showing 2 CT scans, the coronal and the sagittal images showing retroperitoneal metastatic lymphadenopathy and extensive osteoblastic bone metastases with a PSA of close to 700. And after systemic treatment, the patient responded well. We see that the metastatic lymphadenopathy has almost completely resolved. The bone mets have gotten much better, and there is PSA response post-treatment, or 6 months post-treatment. The PSA dropped to 1.1. The interesting finding is in their whole body bone scans, and looking at the CT image and diffuse involvement with osteoblastic bone metastases, we can expect a Superscan pattern at the time of the diagnosis. So this is their first PET Whole body bone scan showing a Superscan pattern. We see intense uptake in the spine, pelvis, scapula, and ribs, with faint uptake in the kidneys and urinary bladder and very faint soft tissue activity consistent with the Superscan pattern. Now, 6 months after treatment, we find that there is still increased uptake. 12 months after treatment, we still find that there is abnormal increased uptake in the axial skeleton, and only on the 4th scan, that was about 18 months after treatment, has the bone scan normalized. And so we know that there is delayed response of bone scan to treatment, and this is how the PSA trended with the bone scan. At 6 months, when the patient had responded anatomically and with their PSA had dropped to 1.1. At 12 months, the PSA was 0.6. At 18 months, it was 0.4. But remember that it takes a long time, up to 18 months sometimes, for the whole body bone scan to show normalization when we have started from the point of a Superscan. This is a good article comparing PSMA PET-CT, the future of prostate cancer imaging, to other modalities. Thank you for watching.